Oh, hi there, it's Claire here. Welcome to Well. I told you on Thursday we had another special episode for you this week. Well, after we caught up with Kate Walsh, aka Dr. Addison Montgomery from Grey's Anatomy, if you haven't listened, please go back and check it out. She is just amazing. After that chat, we invited 4 amazingly smart women to join us on the couch to talk about closing the gender pain gap. Not the pay gap, although thank you very much, we would like that to close too, but the pain gap, where women are experiencing differences in care to men when they're experiencing pain. So often told that pain's part and parcel of the female experience and therefore something to be endured rather than to be treated. On the panel is Professor Caroline Gargett. She is a world-leading reproductive and stem cell science researcher. Fia Baker, psychotherapist who treats women with complex trauma and comorbid pain conditions. She also has her own lived experience of chronic pain herself from endometriosis and osteoarthritis, and she made a submission to the Victorian Women's Pain Inquiry, which she'll talk about. Professor Susan Evans is a gynecologist, laparoscopic surgeon and pain physician, as well as a specialist researcher. And Professor Maria Fiataroni Singh, she's a geriatrician whose research, clinical and teaching career focuses on the integration of medicine, exercise physiology and nutrition as a means to improve health status and quality of life across the lifespan. We just need to again remind you that the information that you're hearing today is general, so it's not specific for you and your particular set of health concerns. So make sure you speak to your healthcare professionals before you do anything. And if you are taking prescribed pain medication, don't stop or change it without speaking to your GP or pharmacist first. Brought to you by Chemist Warehouse. We started off by trying to simply get a better understanding of what pain actually is. So we are talking about women's pain, and I think when you look at the data, we can see, especially from what we got from the Victorian Women's Pain Inquiry, is that women are experiencing pain from a lot of different things for a lot of different reasons, but the overarching conversation seems to be that we're not taken seriously and that our pain is something that we must endure simply because we are women, and that's part and parcel of our journey in life. But what these women are going to explain today is that that is not necessarily the case, and there's lots of conversations we should be having around it. So, Susan, I think I wanted to start with you and just talk about, first of all, how do we measure pain, and what even is pain? It's a feeling. How do you then sum that up and take that to your doctor to explain what is pain?
Thank you, Claire. And you'd think for such an important thing that medicine would have a great answer for that. Sadly, it's still evolving, and there's so much about pain that isn't known. Most pain in humans can't be seen, and that makes it really hard to share. And things we do know is that women and men experience pain differently. Women are far more likely to have a persistent pain condition than men. The mechanisms of pain in women are different than they are to men. And it's still, sadly, one of those black holes of medicine that has been neglected. Things are improving slowly, but needs so much work. So you get down to the only definition is that pain is a subjective experience, which means it's the person that's experiencing. It's hard to measure. Most pain can't be seen. And really, it is, if the person's distressed by it, if it actually impacts their ability to do their normal life, it's a problem.
How much faith do you put in the pain scale? You know how when you
Very
go
little.
to the doctor, I was going to say, right? Because I had a knee injury and I went for decades. And so my level of experience with pain, it diminished over time because I'm used to it, right? So if someone says to me, what's your pain measurement out of 10? I say, I don't actually know, because I don't even focus on it anymore because it's always been there. So if someone is telling you how much pain am I in, like how do we let a doctor know how much pain we're in if that scale is not something we can really visualise?
I think that scale was devised for acute pain. Otherwise, I don't know, you chop your toe off and it hurts and there you go, but it's a short thing and then it heals. It was never really designed for persistent or chronic pain. And so often you have to get down to it's the experience. And you can see somebody who's got certain types of pain that are easy to share, that are short-term, like appendicitis or something like that affects men and women and things. And for those people, the pain scale is probably good. But when you see someone with persistent pelvic pain, they've actually got lots of different pains altogether. And that can be mixed in with fatigue and feeling nauseous and poor sleep and mood disorders. So I don't think the pain scale is any good at all for the whole experience.
Can I ask you too, in your capacity as a gynecologist, how early should we be intervening in pain that's associated with periods? Like I've got a young daughter who's 11, but she's had her period for 2 years now already, and she's doubled over in pain some days. And then I speak to the doctor and they're like, well, yeah, it's her period. She's going to have pain. Like, what do you do with that?
It's such a good question. I think for many women, one of their first pains is the period pain. And if it's distressing and it stops that teen doing what she wants to do, then I think that it deserves careful consideration with a health practitioner that is able to talk to them about it and work out it's the impact more than anything else. Pain almost always starts somewhere, and for so many women it started with period pain. They were often fairly well beforehand. But then what happens is you start to get more involvement of pelvic organs, like maybe the bowel starts becoming a problem, or the bladder. And then you get those aching, stabbing pains when the pelvic muscles become painful and can go into cramps. That's usually the worst pain. And then there's all the nervous system changes that are the feel-bad symptoms. And so I would hope that the health practitioner that your daughter sees will actually look at how much this is, how many different symptoms they have, how many days a month there's a problem, and then think about whether it is important to intervene now or whether this is something that's actually a variant of normal. If your daughter is curled up in pain, having those achy or stabbing pains or movement-related pains, I think she needs care and a thoughtfulness. And none of us want to put our children on medications earlier than they need to, but there's quite a lot of things that can be done that aren't always just hormones. And I think it deserves careful consideration by a health practitioner if it's impacting their life. And it needs regular follow-up, because what's suggested has to work. It's not enough to say, do this and then go away. You need to follow up and say, well, did what we recommend, has it improved things? Is your life now the one that will predispose you to a life of less pain and allow you to develop into the human being with your full potential?
Can I say my medical health practitioner, as Mariam knows, will be very happy to see the back of me because of the amount of times I've said, I work on this podcast and I've learned some things, and he's like, oh. I'm training him up for the next women that come into his practice. That's what I'm telling myself. Thea.
Yes.
Women are often told when we're experiencing pain that it's all in your head.
Mm-hmm.
How do we get past this? Because, I mean, as we've heard Kate explain, you know, she's had to go in and basically say, I'm sure there's something wrong with me. I need to be treated. Mm-hmm. But we're often told, oh, really?
Yeah.
How do we get past that?
Yeah, I mean, we have a lot to be grateful for with regards the ancient Greeks, but the wandering womb making us a little bit crackers is definitely not one of the things we need to be grateful for. But I think this is very much what I spend most of my life doing, and I think it's really important to just kind of from the outset explain, I work from a trauma lens. Most of the people that I work with are firstly women, and secondly women who have experienced trauma throughout their lives, often in early childhood, but mostly all the way through psychological trauma, diagnoses of complex PTSD, and with a big focus on gendered violence. That's most of the work and the research that I do. And through that lens, I very much work from a place of we're a whole system. You know, we can't separate out, you said, what is pain? It's the whole experience of that. So it's how do we support women to understand what is going on in their nervous system and work with the complex intersection of where mental health meets physical health is a real challenge, right? Women being a woman is one of the biggest risk factors for not only having mental health condition, but also experiencing comorbid pain conditions. And the two things have this complicated relationship.
It's really interesting. Before we started talking today, I was discussing an interview that I had done with a woman who was experiencing chronic pain and had been throwing up daily for years, and she'd seen so many different doctors, and they'd basically put her on antidepressants and said that, it's obviously a psychological problem. And then she finds out later on that she has Ehlers-Danlos syndrome, and her skull was like 2 millimeters away from disconnecting from her spine, and that was pressing on her vagus nerve, which was causing all the issues. And we had this discussion about the fact that, and Susan, you were talking about that some antidepressants are actually a good thing in that situation because they do involve things that would be helpful with pain. But the diagnosis that some women get and then get put on antidepressants, there's a twofold thing there. One, how do we push back if it's not the problem? But also, two, how do we get past the fact that some people do need antidepressants, and that's not a bad thing, right?
Absolutely. The stigma around mental health is a huge issue. But also then is this idea that, you're going around collecting diagnoses. So you get that original diagnosis of, major depressive disorder, which is, 2 weeks of depression. That's it. It's a low bar to get that diagnosis, really, or generalized anxiety. And then it's like, well, that's not really what's going on for me. I know something's not right. That intuition is kicking in and saying, there's something else not there. Oh, well, what else do you think is the problem? This idea that, you're being needy, dramatic, hysterical, emotional. There's research that shows, there's this gender bias in the way that women's pain is treated and experienced. And so we have brave men and emotional women. And a lot of this is this old way of how we've trained our medical practitioners, which is changing. And one of the outcomes of the Victorian pain inquiry is around how do we change the system to be more trauma and violence informed, educate our practitioners and, both sides of this to ask different questions, to be more curious about the whole person's experience, and then explain pain in a way that is validating. Because I think that this idea, well, we've got no evidence on this scan, we've done all these tests, there's nothing that supports why your pain that you are reporting is showing up in this way, right? But that's not the only explanation of this pain. And understanding that intersection, if you've got a diagnosis of PTSD, 96% of people are going to then have a chronic pain condition. That's enormous because trauma is a whole person experience. So are we asking the questions, if you're in the mental health field, are you asking the questions about the whole person health? What is going on for them? What other diagnoses do they have around pain? What's their sleep like? All of these things. And then if we're in the sort of physical health medical space, what else is happening for you? Tell me a little bit about your life and where that comes from. Because we know that those adverse childhood experiences has this long-term whole person health effect. Yeah.
Maria, when women age, we experience pain in different ways because there's so much of the focus on women's pain is period pain, or in recent years, and we'll speak about endometriosis with Caroline later, but it's focused on reproductive organs. But as we age, pain shifts really, doesn't it? What are the most common causes of pain as we age?
Right. Well, I think the most common would be some form of osteoarthritis, which can affect, any joint sort of from head to toe. The interesting thing is when you try and figure out, whether the person's physical changes that you see on X-ray or MRI are related to the amount of pain that they have, you can't correlate them. So there are people who have, almost normal scans, but they're in terrible pain, and there are other people who have these scans that just look horrific, and you think they can't even walk, and they don't report any pain. So there isn't really this one-to-one connection, which means you have to look beyond just the joint pathology. And as a geriatrician, everything's connected to everything, and the head is clearly connected to the body, but it's also connected to your exercise and your food and your social relationship and your spiritual endeavors. And so I think when you're trying to help somebody who's in pain, you do have to be incredibly holistic in how you question them. And most of it, I think, comes from the history rather than the physical exam, even though your physical exam, generally corroborates what you're seeing. But certainly in my experience, I think there's a lot that you can do besides analgesic medications. I stop a lot of drugs as a geriatrician. That's what we do because there's so many side effects in older adults. And often, the things that we can do instead in terms of nutrition and exercise in particular and mindfulness are much better than the analgesic medications. And it's clearly true if you look in residential aged care where people are on, sometimes 10 or 15 different medications and sometimes 3 or 4 different kinds of opioids and nonsteroidals. And they're asking for pain medication, but I think what they're really asking for is to be noticed. And probably what we're treating with opioids in nursing homes is loneliness rather than physical pain. And we're not very good at trying to sort those things out. And so the easiest thing to do is to give another medication. And I think we need to be a lot better doctors than that. And, in my personal work and research work, we do a lot with exercise, and particularly weightlifting exercise. And because the thing that happens at menopause really is, tremendous losses of muscle and bone, which lead to all these other problems. And so that's really something we can, focus on and should focus on much sooner than we actually do.
Are you lifting weights, Kate?
Mm-hmm. Yeah, and in fact, I had to start that a few years ago. Like I was always just doing Pilates and yoga or light weights, but actually having to do heavier weights, less rep, and I actually feel it. I mean, I feel it. Like I will get like lower, like L5-S1, like and referred pain down through my hip and stuff, but it is holistic. It's 100%. It is everything, and I feel like the older that I've gotten, the more, I don't know, it's just the opportunity, and yay, I'm grateful, and I mean that, but it's like more layers of the onion come off, and you're like, oh, there's more opportunity to look at early childhood trauma that I thought I'd sorted or dealt with, or I work out in my, TV shows or whatever, and then add to it, bone density and muscle mass and all the information that we have around that now. But I literally feel it and see the effects straight away. Like I was traveling in LA and to go back to do Grays, and I didn't have my regular weight training protocol. So I was doing just yoga and ballet and Pilates, and I felt it immediately. I started feeling my lower back and this right sort of sciatica hip thing because I wasn't doing my heavy lifting squats and the endorphins and serotonin and all. I mean, that's like, that's just all of it. I get all the good.
Head to toe.
Yeah.
Something too, Maria, that women experience as they age is this idea that they're no longer really worth fixing, that we've reached a point where, and I mean, it's easy to blame the patriarchy for everything, but like when you're no longer in the male gaze, right, you kind of feel maybe you've faded away from existence a little bit, and this idea that women as they age, they kind of go, well, I'm no longer as important and this kind of becomes part of that loneliness discussion too, is that we see ourselves as only being important when we're vibrant or maybe during our childbearing years or whatever that might be. So how do we let women know that, even if you're 80, you're still worthy of the best medical attention?
Absolutely. And I mean, the first studies we did were people in their 90s, who were very frail in a nursing home. And we weren't trying to get them, to go back and live in the community, but really just to be able to be more functional, in their own environment. And so functional longevity is really not even necessarily healthy longevity, because how many diseases you have doesn't really relate to how functional you are. If you just list all the diseases somebody has, that's really not the whole story. It's really about, can you do what you would like to do in your life, whether it's taking care of your children or your grandchildren or doing volunteer work or still working. My mom's 96 and she works every day running a music store, and she's never going to retire, but not everybody wants to work, but other people want to do other stuff.
Does it help having a geriatrician as a daughter?
Well, she doesn't listen to me at all. She's never picked up a weight and never will, but she's a pianist, so she does other things. But so I think you need to sort of think about function rather than disease. And if you do that, then that's what you can give people. Because the thing is, we don't have any drugs for frailty or sarcopenia. We have drugs for osteoporosis, but they don't prevent you from falling. And if you don't fall, you're not going to break your hip. So we don't have drugs for the most important things that affect people as they get to old age. But we do have non-drug therapy like weightlifting exercise and other kinds of exercise and other kinds of psychological help and good nutrition, and we're not doing that enough. And the problem is doctors. I mean, I didn't get a week's worth of menopause, education in medical school. I think we got an hour. We got 0 hours of exercise and 1 hour of nutrition, but it was about scurvy and beriberi. It wasn't about malnutrition.
For when we go back to become pirates,
and that was 1977, but it hasn't changed. Unfortunately, it hasn't changed at all. There's still no training about this drug we have that cuts your risk of heart disease in half, called exercise. We get no training about it. So, and I think the important thing is that if you start at menopause, it's probably a bit too late. You reach your peak bone mass at age 20, muscle mass about age 30. And then it stays okay until about 50, and then it's pretty much downhill. But we have the antidote. We're just not using it. Yeah.
Caroline, sorry, we've left you a bit bereft there at the end of the couch.
I could bob in on the endometriosis and the point that Maria made about the scans did not match the symptoms. This is very classic of endometriosis, where you can have very severe pain, but they can't really find anything when they look surgically to see whether there are some endometriosis growths. So it makes it really quite difficult to know how to treat or how to diagnose as well. So, and then many women go through a lot of steps to actually get a diagnosis, and it's actually quite distressing, I think, for women that perhaps have this severe pelvic pain, and it's a negative laparoscopy, and they don't actually have endometriosis after they've gone through many consultations and doctors and gynecologists to even get there, and what happens next. And that area is still really open. I think Susan knows more about that too.
And can I say that, if someone has a whole range of pelvic pain symptoms, and it sounds like they've got endometriosis, but they have their laparoscopy and there wasn't any endometriosis found. It's a beautiful pelvis. And I have so many times gone round to see women after I've done their surgery and say, your pelvis is beautiful. And then they start to cry. And really it should be a cause for celebration because it's a problem they don't have. But I would see that as, yes, most pain in humans can't be seen, and we will keep working with you on all the pain regardless, whereas they are seeing it as you can't see something to remove, and therefore there's nothing that can be done. And I think that's where the big gap is. It's like people are thinking that if I've got pain, there has to be something to see, and if there isn't something to see, then I'm crazy. And that's where the problem is, when really it is that you've got pelvic pain, endometriosis lesions might be part of it, they don't have to be part of it, but managing the big picture of their pain is actually the crucial thing.
Well, I wanted to ask you too, Caroline, there's been a lot of headlines of late around endometriosis care, and there's a particular surgeon that we won't go into too much detail on who has been accused of doing unnecessary surgeries on women, and that has a twofold impact. One, for women who have endometriosis and have undergone a lot of surgeries are worried that they've now had unnecessary procedures. But also there's the others who say, well, I need the procedures to find the endometriosis, so it's necessary and a part of my treatment. How's that been received for you and your colleagues?
Well, that's why we're really looking to try and find a non-invasive type of diagnostic for endometriosis, because that's really where the issue and the problem is. It requires surgery, and really it generally starts in girls. Soon after they menstruate, they start to have this period pain, and the lesions perhaps are starting there and they can progress. But you can't really do a laparoscopy on a 12-year-old girl, for example. So we're really keen to try and find another way. And many researchers have been looking. They've been looking in blood. They've been looking in urine. We're looking in menstrual fluid, and menstrual fluid has actually got endometrial tissue in it. It's live too. That's living tissue in there. And so it's actually a non-invasive way of getting endometrial tissue. Women who've got endometriosis, their uterine tissue, their endometrium, is different to those who don't. for example, at the molecular level, quite deep molecular level. So these are the sorts of things, if we can then use the tissue in the menstrual fluid and look at that and find some markers and things like that, that can give an earlier diagnosis. That's sort of where we're looking at. Others are looking in other areas, and I have to say that very late last year, a validation study now was published in the New England Journal of Medicine Evidence, and they've got a saliva test. And I don't know how, Susan, you treat endometriosis. It's very new. I looked at the figures and it looks pretty good. It looks better than imaging. So it'll be interesting to see if there's uptake for that type of thing, because that could be done before doing all those surgeries, for example.
Caroline, can we just discuss how glorious menstrual fluid is? Because, doctors and researchers and scientists have avoided using it as a diagnostic tool for a long time. And I was reading about a lab in particular when some researchers wanted to do some testing on menstrual blood. They said they didn't want that kind of dirty material in their lab. Yeah, it's wild. So can we just talk about the potential for menstrual blood as a diagnostic tool for women?
Yeah. Well, and that is an issue. There is a yuck factor. And I can tell you, I've been putting in grants to try and build a biobank, and it's very difficult, because I kind of feel that people look at this and think, oh no, we don't want to look at that. So that's part of the problem. But I think, menstrual fluid, there's lots of aspects that we can look at. There's the immune cells, so we can look at those, because inflammation is a big part of endometriosis, and inflammation causes pain. So that's one aspect that could be looked at, for example. We can do things with the living tissue in there, and we could test drugs on those, for example. There's lots of proteins in there and lots of other things in there that can be measured. And one of the studies that we did actually is we got 11 women and we got them to give us 5 or up to 5 consecutive periods using a menstrual cup. And we analysed those, and we analysed them for several things, some of the endometrial stem cells we were studying and also some of the proteins. And what we found was they were quite consistent, but I think what we can say is that menstrual fluid actually is quite valuable, because if you test it once, it's going to be quite similar if you test it again. And I think that's a fairly important thing, and it also can detect sort of things that are different in different women. So that's where we're just in the starting phase, but there's sort of the types of things that we've been doing.
Some very exciting research field going on there. Susan, when we're talking about endo and inflammation and things like that, something that I've spoken to you about previously is this understanding of the role that our immune system is actually playing in our experience with pain. Can you describe that for us?
This is a really exciting space, and I think this is going to be so much more important for women's pain than men's pain.
Hooray!
Yay! So, our immune system has 2 parts. It's got the cells that travel around the blood. They're called macrophages, and at period time they flood into the uterus and they get activated, and they then travel around the body. No surprise, it's a systemic thing. And then there's the immune cells that live in the central nervous system. They're actually called glia. And when I was a medical student, they were thought to be just nothing. They were just the stuff that held things together. They're actually a really important part of our immune system. And so much of the cutting edge in pain research is that people with chronic pain have too much activation of their immune system. And it might start with immune things in the body, but then it tells the immune cells in the central nervous system what's happening. And if there's too much activation, or activation regularly and repeatedly, like multiple episodes of it, then the immune cells in the central nervous system get overactivated. They change the way the nerves work, and they sensitise our nervous system to pain. They work like an amplifier, which means that even small things like a small noise gets amplified up into a big, loud, unpleasant noise by this sensitivity. Now, women often come to me and they say, I've got a really weak immune system. I'm always sick. Someone at home will have a virus, they all get better. I'm sick for days and weeks, and I'm just so much worse than everybody else. And they think they're weak. Actually, it's because women have such a strong immune system that they have a really big reaction to things that don't make as big reaction for other people. And that strong immune system, particularly in those women with endometriosis, persistent pain, those sorts of things, has advantages and disadvantages. Women are less likely than men to die of an infectious illness. We saw that in COVID. But they are more likely than men to have a chronic pain condition or to develop an autoimmune condition. So women and men are different. Pain in women and men is different. The mechanisms are completely different, and the immune system is absolutely essential. And one of the big drivers of immune activation is painful periods, the immune system in our gut, all those things that happen again and again.
We're going to have a discussion about the connection between our guts and pains and brains at one stage. We don't have enough time for that today. But Thea, I wanted to end today just to ask you about your submission to the Victorian Women's Pain Inquiry and your personal experience, because you did it sort of on behalf of your patients too. But
it was a weird day. I'm the kind of person that when an email comes in, I'm like, delete. If it's,
she almost deleted us because she thought we were spam.
I know, I did. Did read it a second time and go, oh no, maybe this is legit. And instead of just going, oh, flag for later or delete, I was like, oh no, this matters to me. Matters to me as a woman who's experienced a collection of pain-related things since I've lived in Australia for the last sort of 15 years. And like I said, because I feel like as a well-educated white woman, I have the capacity to advocate for myself and push back, and I don't mind pitching up to a medical practitioner 3-4 times and saying, no, that's still not quite right. This is what I think might be going on, or please can you have another look. It's not the same for a lot of my clients, and advocating for them was a really big part of it. So I pounded away on the keyboard. I have no idea what I actually wrote now. I can't tell you. I think it was like a 5-minute word vomit. Explaining, I've had multiple surgeries. I think I've had 7 in 10 years. Gynecological ones, 4 hip surgeries, a hip replacement. I've had to have my wrist put back together again with plates and screws. And I've had these various responses from medical practitioners. And sometimes I've had to feel like I've been doing the work for them and thinking, oh, you didn't ask me quite the right question there. And I mean, I could be really graphic if you want me to be.
By all means.
But just before we left the UK, I'd had an abnormal pap smear result. And I'd been to see a gynecologist there and had a LETS procedure where they basically, burn a bit of your cervix off, which is delightful. And the gynecologist said to me, okay, well, the first thing you need to do when you get to Australia is get a gynecologist because you're going to need to see them every 6 months for checkup. So I made friends with the gynecologist, had checkups, had a couple of laparoscopies, and because I kept having this kind of post-coital, post-sex crazy bleeding. It was like a bloodbath and it didn't really make sense. So I kept going back and I'm going, is it because my pap smear result, is there something? Have I got cancer? I've already thought I had cancer 3 times already now. He's like, no, that's all clear, all good. I think maybe we just put a marina in. And I'm like, I don't want a marina. My husband at the time had hysterectomy. That's the one. And I was like, I don't really want to do that. I kept pushing back. He said, well, we had a little clear up. You had a little bit of endo, but it wasn't, anything that would make sense of the pain and the experience that you're having. Just come back and let me know if it's a problem. And there was just something niggling away at me. All the way through, everyone, the gynecologist in the UK and this one was like, so after you had your first LETS procedure, how's sex? I was like, it's fine, thank you. Because what I didn't, there wasn't a lie, but what I didn't say was, I oh, well, I'm not having sex with my husband right now because things are really tricky and I'm quite happy with not having sex with him. But you didn't ask me, have you had sex since the procedure? You said, how is sex? The assumption was I was having sex with my husband. So I just didn't lie. I said, it's fine, thank you, because it was. It wasn't until after when I'd separated from him, divorced him, and was seeing who would then become my second husband, that this whole bleeding thing, because I'd started having sex, was my thinking. I was like, oh, these two things are connected. Maybe it just didn't heal properly the first time. So I went back again, had another procedure. I said, could this be what was going on? I hadn't had sex, now I'm having sex. Do you think maybe it's not healed properly? He's like, oh, maybe that is it. We'll go in and re-burn your cervix. Problem solved. But it was me having to go back. And so it was this sense of, it's just extra efforting. And I feel like that's what, we do a lot of as women, all of this extra mental load. And I was doing that for myself, but you said, Kate, your recovery was about, a lot of it was taking someone with you, having someone there as your support person, attending appointments. That is a huge piece of it. And my submission to the pain inquiry was in part to say, yeah, I've experienced this and I don't mind being a noisy advocate for myself. But it's, what about the intersections of women who have complex mental health, are women of colour, are people born in female bodies, are non-binary? How are we supporting those people? Yeah, it was, and then I just ended up being a poster girl for them, unplanned, but
amazing.
Yeah.
Well,
yeah.
Thank you for doing that. It is really important to tell stories like that so that there is a broader understanding of women's experiences in the medical profession. But final question, who sitting here right now is experiencing pain? Anyone? Are you experiencing pain right now in your body?
No.
No? Small?
Yeah. I still have a broken coccyx bone, so sitting here like this it's starting to creep in. Kate?
I'm all right.
You're okay?
Yeah, that right hip's okay. But I mean, I'm kind of woo-woo too, though. I am like, I'll try anything. I still go on Instagram and like, oh, okay, I'll try that. I'll meditate and focus some light here. And so whatever, I did a meditation on my little hip and lower back, and so far so good
There you
today.
go. Okay.
It's a long-winded answer,
That's
sorry.
good. No,
But on the
that's
plane
good.
yesterday, it was killing me sitting.
Yeah.
It was like,
Yeah.
And this is really informative. I love hearing about that you have scans and you're not going to necessarily see, and that mentality, because we do. You're like, and also it's in the zeitgeist. We're socialized to think if you don't see it on an MRI or an X-ray, it's not there. So you feel like, well, what's wrong with me then?
And the disappointment and the mental health impacts of that afterwards is
and then you feel like a
strong.
whiner, and you're like, why aren't I better, stronger, faster?
And I do think the bar is held so high for women to prove their pain,
Oh.
in that if you think about migraine headaches, everybody knows they're painful, but nobody expects to see lesions in their brain on a scan. They just accept that they're painful. But for women, it's like when they've got pelvic pain, it's like, have you got endometriosis lesions? That's about it. In other words, it has to be something to see.
Endo or nothing.
It's endo or nothing, and that's not how it should be.
Yeah, absolutely. How are we feeling down that end?
Well, I do have a little bit of pain in my back here because I've had massive back surgery.
Oh, gosh.
What I need to do is get up and stand for a while and walk.
Same here.
I walk a lot
Yeah.
to support my back and reduce
There's
the
that
amount of
exercise
pain I
again,
have.
Maria. Can we find a way to make exercise enjoyable?
All I can say about pain and gender is that women go through labor. I've done that 6 times. Men get the man flu. So who's stronger, really?
How are we feeling in the audience? How's our pain levels today? Put your hand up if you're experiencing pain sitting down right now. Yep. Hopefully the discussions that we're having here today will either get you to stand in front of that medical professional and demand them to take you seriously, or hopefully that medical profession is listening and can also understand when we do stand in front of them and tell them that we are in pain, they take us seriously. But thank you to everyone who is on the panel today. We've really appreciated all of your input and for stealing all your expertise. We thank you very much. Thank you to everyone for coming to this today. We really appreciate it, and we hope to have you join us for season 2 of Well. Thank you. What incredible insights. We are so grateful that these women took the time to speak with us and share those experiences too. And thanks again to Kate Walsh for staying on for the conversation. She was incredibly generous. In fact, she spent a bit of time after the interview wrapped up chatting with the experts about their experiences. Thank you for that, Kate. Next week, we're going to talk about big, gorgeous, giant babies, what exercise actually helps with your mental health and how quick it can blow away a black cloud, and how much pain is quote-unquote normal many years after a hysterectomy. That's next week on Well. We'll see you there. Well is produced by me, Claire Murphy, and Sally Best. Our group executive producer is Ilaria Brophy. Audio production by Scott Stronach, social production by Ellie Moore, and video production by Julian Rosario. Brought to you by Chemist Warehouse.